This conference will now be recorded.
I apologize for those of you who may have missed the beginning of this. It's going to be okay. You will be all right. As long as you read the chapter, you got this. Okay, so yes, your lactose fermenters, your non-lactose fermenters. Thank goodness for you guys, because you guys really helped me keep it together. But you know what? It was because I had that whole commotion situation with my vascular access team coming in. It threw me off my game. Okay, so we've got our growth of Enterobacteriaceae McConkey's agar here. So you've got an uninoculated plate. This is what it's going to look like. And then your colorless colonies are those lactose non-fermenters like Salmonella, Shigella, Proteus. And then your pink colonies are going to be your lactose fermenters like E. coli, Citrobacter, Klebsiella, and Enterobacter. Okay, so let's do a quick concept check. Enterobacteriaceae are associated most often with which of the following healthcare-associated infections? 1 is pneumonias, 2 is surgical site infections, 3 is bacteremias, and 4 is urinary tract infections. We got a D, we got a C, we have a B, another C. Okay, the C's are winning. Another B, and now we're tied. Let me give you another couple seconds here. Okay, so it looks like the populace is stuck between either B or C, and they're both kind of winning. It's just kind of going back and forth. We're getting lots of points for both answer choices. Wait a minute. Okay, please hold, because the correct answer is D. The order of this was incorrect, but yes, the correct answer is D. So we find these in all of our HAIs, and they are our gram-negative Enterobacteriaceae family are the most common causes of all of our HAIs. So it's 1, 2, 3, and 4. The most familiar species recovered from extraintestinal diseases are going to be our E. coli, Enterobacter cloacae, Klebsiella pneumonia, Serratia marcescens, and Proteus mirabilis. Salmonella species and Shigella species and E. coli are common agents of gastroenteritis and colitis. So here's our bonus question. There are 2 species of Salmonella for which humans are the only reservoirs. What are they? What are they? Typhi is 1. Very good. So everyone put typhi and paratyphi. Very good. Yep. So Salmonella typhi and Salmonella paratyphi are those that are only carried by humans. And about 1 to 5% of patients can become chronic carriers. So for those chronic carriers, what is the reservoir in most patients? For those chronic carriers, where does the Salmonella end up hanging out, making a home? It's inside of our bodies. That's my clue there. Yeah, GI, okay, but specifically, one specific location. Anusha, you got it correct. Yes, the gallbladder. The gallbladder is the reservoir in most patients. Listen, we need to unpack that, but we don't have time today, so we will dive a bit deeper into that. Okay. We come back to this. Because this is going to be on your test. There's no way around it. They will ask you about gram-positive and gram-negative organisms. I've already explained to you why they're going to ask you about this. When our providers order these cultures and they're sent out, and we're keeping our eyes on the prize, checking our micro labs, hopping in and looking at, what is growing. One of the first things that we're going to know is it gram-positive or gram-negative? And so immediately, as an infection preventionist, you should be thinking, okay, well, if it's growing gram-negative rods, I'm thinking this. If it's if it's growing gram-positive coccus, I'm thinking that. Like, you should immediately start thinking, and they want to make sure that you understand this. So our Enterobacterialis, Enterobacteriaceae are going to be on the gram-negative side, which means that you have to remember that they're dealing with their lipopolysaccharides, of which you have your three major components, which is the O polysaccharide, the core polysaccharide, and lipid A, right? So you've got your LPS situation. So lipid A is really what causes the inflammatory effects of LPS, and that's what we're really responding to when we have some very serious reactions, like those cytokine storms, cytokine productions, fevers, etc. You're paying attention to that LPS and your lipid A. So that being said, which of the following virulent factors associated with Enterobacteriaceae are associated with septic shock and DIC, which stands for disseminated intravascular coagulation? A, flagellar H antigens, B, capsule K antigens, C, pathogenic islands, or D, LPS, polysaccharides, and lipid A endotoxin. Okay, so I kind of gave this one away, but it's because it's important. So you don't have to be a full-on microbiologist. We have many IPs who are microbiologists, and you know what? They're out there doing the thing, killing the game, being absolutely excellent. This is some of the things that they mention in the APIC text. Our cell walls, that LPS polysaccharides and lipid A, and it tells you that it's common to all aerobic and some anaerobic gram-negative bacteria, which is released upon death. It activates macrophages, white blood cells, releases cytotoxin, causes septic shock, necrosis, DIC, and death. So because we've got this really intense immune response, they're wanting to make sure that you know about it. Now, they may ask about flagellar H antigens or capsule K antigens or pathogenic islands, but the likelihood of that is much lower. So question 1, Mrs. Smith is a 75-year-old female with a past medical history of breast cancer, COPD, alcoholism, and liver cirrhosis. She was admitted to your ICU with a high fever and diagnosis of shortness of breath. Her chest x-ray revealed a primary lobar pneumonia. For the past 2 days, her sputum has had a red currant jelly appearance. Her sputum culture is still being processed in the lab. Based on her past medical history and her current symptomology, what pathogen do you suspect? Okay, so I have answer choices. I've got lots of B's, some C's. Okay, very good, very good. So our answer is going to be Klebsiella pneumoniae. And one of the ways that that helps me to really remember that red currant jelly appearance when describing Klebsiella pneumoniae as that pathogen or that organism that causes it is this picture. Because it's okay, yes, it's gross. It's a very gross picture in the sense of like the thought process behind it. But hey, if you find ways to remember things, as long as it works. So you've got Klebsiellas homemade red currant jelly that should hopefully help you remember that red currant jelly appearance when it comes to our sputum and when our patients are coughing. Now, Sketchy Micro is a great resource, and they have this video where they talk about Klebsiella and Enterobacter serratia, and they have all of these great interactive ways of helping you remember facts about all of these different bacteria and how they interact with the body, the kind of infections that they cause. So um, let me see if I can post the link to it now, just because I know that I'm going to get questions for it. So give me 2 seconds and I'll post it in the chat so that you guys have access to it. Okay, so I've got the link here. to everyone. Okay, there you go. So that you guys are able to watch that at your own time and really get to learn more about it. Okay, now we're back to this situation. All right, so treatment of Klebsiella infections have become problematic in several regions of the country due to the increasing prevalence of carbapenemase-producing strains. And we know lots of issues with antibiotic resistance. We've talked about antibiotic resistance in the past, antimicrobial resistance and all of the issues that we're having with combating just the amount of resistance that's happening just worldwide. It's very, very concerning. It's actually really exciting. I got some really great news today about our HAI program here in Florida. They're going to be expanding their program and having quite a few positions opened up for antimicrobial resistance and all sorts of other issues, which I think is excellent for our state. So these strains produce broad spectrum beta lactamases that inactivate all beta lactams. So what are some common antibiotics under the class beta lactam? What are some common antibiotics under the class beta lactam? Okay, I'm getting lots of different answers. Okay, let me tell you what I'm reading. I'm getting cephalosporins, penicillin, fluoroquinolones, penicillin, cephalosporins. Okay, so beta-lactam antibiotics are a class of broad-spectrum antibiotics consisting of all antibiotic agents that contain a beta-lactam ring in their molecular structures. This includes our penicillin derivatives, cephalosporins, monobactams, and carbapenems like imipenem, meropenem, ertapenem, and aztreonam. So our carbapenem-resistant Klebsiella pneumoniae, or CRKP, is the most frequently isolated carbapenemase-producing Enterobacterialis, which is going to be, so, okay, this is, let's talk about this, because a lot of our bedside staff get confused with Klebsiella pneumoniae. How many times do you find that staff automatically will, if depending on the team member, will automatically place a patient who has Klebsiella pneumoniae under contact precautions? Because I see that happen, where they'll see Klebsiella pneumoniae and they'll think like, oh, this is KPC. But that's Klebsiella pneumoniae carbapenemase. So I have noticed that there are often times when people get those confused because they're, the name is familiar, it sounds similar, but it's a little bit about understanding more of like that carbapenemase and that antibiotic resistance. So there's been times when we have had to have conversations. No, this is Klebsiella pneumoniae. This is KPC. Let's learn about the differences. I know that they sound very similar, but let's let's like talk about it. Let's understand why this person doesn't need to be on contact. It's a very friendly Klebsiella pneumoniae, susceptible to a lot of antimicrobials, and getting that chance to do that education. Okay. Yes. Okay, question 2. David is a 3-year-old male presenting to the ED with symptoms of abdominal cramping and watery diarrhea for 12 hours. Upon physical examination, the patient appears lethargic, has diffuse abdominal tenderness, and has dry mucous membranes. While examining the patient, he has a bowel movement of watery diarrhea that is grossly bloody. The mother is unable to state when the patient's last urine output occurred. The patient's laboratory workup reveals an H&H of 7 and 18. The patient is in acute kidney failure and has a low platelet count. What pathogen do you suspect? Now keep in mind what we are talking about today. Enterobacterales, Enterobacteriaceae, right? So you know that it's going to fall under that category. So what pathogen do you suspect with this presentation? Okay, E. coli. E. coli, about which one? It's a very specific one that we're thinking about here. Linda, you got it. Very good. E. coli O157H7, yes. And this complication that we're discussing here, it's going to be hemolytic uremic syndrome, and this YouTube video, you can feel free to watch it. It really goes into a story involving hemolytic uremic syndrome for a child. And so some of the common sources of this pathogen are going to be our uncooked or raw hamburgers, milk, apple cider person and person-to-person transmission in daycares and nursing homes. Some of, you know, I wonder if this is reportable nationally or if it depends on state by state. It might be state by state. It's difficult. Well, let's talk about it. It depends. Okay, absolutely. It is. It's reportable in California. It's reportable nationally. There we go. Excellent. So yeah, it's a big deal. We have to make sure that this gets reported and that you kind of understand this specific complication and this pathogen, because they make sure that they go into the text, and you want to make sure that you know about it. I've never had a case. I've never had a case that I've had to report personally here at our facility, but I'm sure that many of you have. And then one of our most common complications of E. coli 01 1157H7 among the elderly is thrombotic thrombocytopenia purpura. All right, so question number 3. Members of the order Enterobacterialis include gram-negative, short cocobacilli or straight non-spore-forming bacilli. These organisms are facultative anaerobes. So please define a facultative anaerobe. You've got different tubes here. You've got tube A, B, C, D, and E. Which one of these is going to be a facultative anaerobe? Oh, it looks like some of you have worked outbreaks with E. coli. 157H7. Interesting. That's great. Okay, so a facultative anaerobe. Okay, let's see. Who got this one right so far? Lisa Ma got it right. Aneki got it right. Mona got it right. There's somebody who's just named user, so I don't know who you are, but you also got it right. Okay, so with our facultative anaerobes, it's going to be B. Okay, it's going to be B. And this helped. Okay, so I'm going to tell you why this picture was so important to me, because sometimes I just get confused in life, period, right? It happens to the best of us. And for me, like visual, I'm a huge visual and auditory learner, more auditory than visual. Like I love, so when I take tests or exams, which by the way, guys, I'm getting ready to go back to school, so let's talk about that another day. But when I take exams or when I take certification tests, I can actually like hear things in my head, like remembering. Like I remember when I was taking my vascular access board certification, which is the most recent certification that I took this past summer. I could hear Lily, who was one of our vascular access nurses, telling me things as I was watching a pick insertion, like answering questions, like her talking to me about the barred Sherlock and the positioning of the tip, the location, the rhythm that we would be looking, like all of that, like that auditory stuff really helps. And visually, this also helps me because definition wise, it may confuse you, but if you start thinking of it in terms of a tube that has oxygen and no oxygen at the bottom, it really helped me. It really helped me on my exam and just in general. So the answer is B, facultative anaerobe, both aerobic and anaerobic growth, greater growth in the presence of oxygen. So growth is best where most oxygen is, which is why we have all of them, bundled up at the top, but it can occur throughout the tube. All right, question 4, and we gotta I don't know what's been going on. I feel like I haven't been going as quickly as I should, but BSIs or bacteremias caused by Enterobacterialis are usually a result of continuous spread from the urinary tract, lungs, or GI tract. Other portals of entry include surgical sites, decubiti, and central venous lines. In the latest data from NHSN, they accounted for 19.6% of infections. Which of the following was the most associated with bloodstream infections? So we've got Klebsiella species, which is A, B is Enterobacter species, C is E. coli, D is Serratia species, and E is Proteus. So which one of these was the most associated with bloodstream infections? Okay, very good. For those of you who put A, it's our Klebsiella species. So this is broken down by Klebsiella, Pneumonia, Claudia, and SSI. And so you can see that here for your Caudi's, E. coli is the highest. And I think that this is really, and then you see Klebsiella, you see Klebsiella pneumonia is the highest for your Klebsiella. But Caudi's, this is so important because I feel like this is one of the questions that I've seen come up over and over again in practice tests. And I don't, so it's been a long time since I've taken my test. But I feel like this is one of the things that did come up, which was regarding, E. coli being very common for causing UTIs. It's the leading cause of Caudi's with 47.9% in the 2009 to 2010 NHSN survey. E. coli was the top pathogen recovered from Caudi's. All right, so question 5. A 10-year-old boy is admitted to the hospital with a 3-day history of fever, abdominal pain, diarrhea, and vomiting. He and his family have just returned from a week-long camping expedition in the mountains that include trips to the seashore. A stool culture is reported with many lactose-negative colonies. Which of the following is the most probable causing organism? Oh, sorry. So it's gonna be C, Yersinia enterocolitica. This is gonna be one of our organisms that can cause a variety of infections depending on the age of the person infected. Infection with Yersinia enterocolitica occurs most often in young children. Common symptoms in children are fever, abdominal pain, and diarrhea, which is often bloody. Symptoms typically develop 4 to 7 days after exposure and may last 1 to 3 weeks or longer. In older children and adults, right-sided abdominal pain and fever may be the predominant symptom and may be confused with appendicitis. In a small proportion of cases, complications such as a skin rash, joint pains, or spread of bacteria to the bloodstream can occur. Okay, so quickly, true or false? Members of the Enterobacteriales order include gram-negative short cocobacillary or straight non-spore-forming bacilli that grow well in the presence or absence of oxygen, so they're facultative. Is that true or false? That is true. The next thing is the emergence of carbapenemase producing Enterobacteriaceae is a mounting public health concern. True. True, true, true. Yes, it's true. And so CDC has all of these really interactive maps that you're able to get onto their site, which will show you um, carbapenemase producing CRE. And not just Enterobacteriaceae, so they even have one like for Pseudomonas, Acinetobacter. They've got their maps are really they're really fun and interactive. You can click on your state. It's divided out into different categories. I'll try to find the link and post that on here if I can. Although I know it's buried in my email, but it's well, actually, I feel like it's not buried in my email. I feel like I have it in one of my sticky notes here on my desktop, but I'll see if I can find it. Okay, so next we're going into Legionella. Now, there is an amazing podcast. Okay, it's called Sawbones, where it's this wife and husband, and they go back and forth, and they talk about all of these different like medical situations, um, history. How many of you listen to the Sawbones podcast? I know it can't just be me. I know you're all out there. Yes. Okay. There are other people. They're like, I love them. Me too. They're hilarious. Okay. They're hilarious. But anyways, there's a podcast that you need to listen to where they talk about Legionnaire's disease and Legionella, and it is amazing. And it's actually one of my slides, but it's just such a good podcast. It's funny because I was talking to my brother-in-law about this podcast because he was asking me questions. This is how it happened. We were watching Scrubs, and there's an episode where JD John Dorian walks into a room, and there's four doctors, and they're like all laughing, and they're like, yeah, well, we just came from a medical convention, and we're pretty sure that we have Legionnaire's disease. And I was cracking up. I thought it was the funniest thing. This was literally this week. I'm like, that is hilarious. That is so funny. And he was like, why are you laughing? Like, I don't get the joke. So picture this. I'm on the couch. He's sitting next to me. We're watching Scrubs, and I'm literally telling him, like, listen, there is this amazing story about Legionella that you need to listen to. And it is just such a good podcast. I said, I'm not even going to tell you the whole thing, but this is what you need to know. And this is why this joke is so funny. But um, look, I'm just very passionate about Legionella. I think it's a Legionella pneumophila is such a fun bacteria, and just the history of it all, the drama, it's just great. So background, it was identified in 1976 at the American Legion Convention held in Philadelphia, at the Philadelphia, Pennsylvania hotel. These are aerobic, so they love oxygen, gram-negative fastidious bacteria, which means that we require specialized culture media to grow them, because if something is fastidious, it is difficult to grow. How are we going to test for this? Urinary antigen detection. Yes. Um, you have to remember that, because it's going to be the easiest way to do it. It's the most common way to do it. It's what we use for testing primarily. So Legionnaire's disease, it's a pneumonia, and then you've got Pontiac fever, which is a flu-like illness. And the CDC estimates that less than 5% of cases are diagnosed and reported to the CDC. And I agree, because often I feel like a lot of times Legionella is kind of on the back burner for some of these diagnoses. Like you're ordering a sputum culture, you're looking for all of these other things, and I feel like ID is very good about it. ID is very good about, ordering, like placing that Legionella urine antigen testing, but I think some other specialties, like it's kind of not at the forefront of thought when it comes to some of these scenarios, but that's what you need to know about testing. So our clinical presentation for Legionnaire's disease, which we got to remember, it's gonna be where we have that pneumonia. So the incubation period is about 2 to 10 days. Our associated symptoms are non-productive cough, fever, shortness of breath, malaise, myalgias, anorexia, headaches, confusion, watery diarrhea, nausea, vomiting, and abdominal pain. Some common things that we'd be looking for laboratory-wise are hyponatremia, and with our chest x-rays, it would be infiltrates. Again, remember, hyponatremia happens when we have a low concentration of sodium in our blood, so it's abnormally low. And sodium is an electrolyte that helps regulate the amount of water that's in and around our cells. So for Pontiac fever, the incubation is 24 to 48 hours. Associated symptoms are high fevers, chills, myalgia, and headache. But symptoms usually resolve within 2 to 5 days without treatment. So here's where they break it down again. So you've got your Legionnaire disease, which our portal of entry is respiratory inhalation. You're going to inhale the Legionella in. It can cause bacteremia, can vary from mild to severe to fulminant systemic disease and death. And then you've got your Pontiac fever, which is acute, self-limited, and febrile, and typically not fatal. So what are some of our risk factors for Legionella? Advanced age, male gender, cigarette smoking, alcohol abuse, chronic pulmonary disease, immunosuppressed hosts, renal failure, and corticosteroid usage. So all of these things are very important. And when I was working at the health department here locally in Florida, we had this massive outbreak that was associated with these gyms. It was these different gym locations, and it was happening primarily. So we had Legionella cases that were happening primarily in the older population, those who were greater than 65 years of age, and it was being associated with some of like the aquatic aerobics. So um like aquatic aerobics, and I guess the setup is like the what do you call it? The hot tubs were like close to the pools. It was all of these different things that were going into it. They found Legionella in lots of different locations. So it's important to know these risk factors, because it's really going to help us. with keeping that in mind, even though, unfortunately, these are a lot of risk factors that can be correlated or associated with other issues. So pathogenesis, so let's talk about the natural habitat. Okay, sorry, my VATH team is messaging me. Okay, so our natural habitat is going to be water. So I love water pathogens. I don't know what it is, but I just love those pathogens that love water. I find them the most interesting. And I don't know why that is, but that's how I feel. Modes of transmission: direct inhalation or aspiration. Person-to-person transmission does not occur, but okay, that's what your text is going to say. But we do need to talk about this one case, and it's just important that we know about it because I don't want you to be like, Lou's never told me about this case that happened in Portugal. Okay, so this happened back in 2014. Um, um, Wait, no, he had been employed. He had been employed there since 2014. So it's a 48-year-old male, this patient, a smoker, who'd been employed at this industrial cooling tower complex in Portugal. And he ended up becoming very sick. So he started to get really ill, with symptoms of Legionnaire's disease, severe respiratory symptoms, and intense cough. And he went home, and his mom was helping to take care of him. Mothers love to take care of us. That's like one of the, they love taking care of their children. That's what moms do. So she was like taking care of him, trying to help him. What ended up happening is that he got so sick that he ended up having to go to the hospital. So he gets admitted. They find out that it's Legionnaire's, Legionella, it's Legionnaire's disease. He gets placed on ECMO. All right. So I'm talking like critically ill. Then his mom gets sick. With what, you ask? Yes, you heard it here. Legionella pneumonia as well. The saddest thing about this whole thing is that both the mom and the son died. Okay. They died due to septic shock and pneumonia. All right. The mom died on December 1st, and then the patient died on January 7th of 2015. So that's to say, this is what we have documented. But when it comes to that, when you're thinking like, do I need to place a patient who has Legionnaire's disease on do they need to be on a specific type of precautions? You're going to follow your standard precautions. So if somebody has, a questionable cough, or if they're coughing, like obviously we're going to tell our staff to, use droplet precautions, but it is not, so it's going to depend on the symptoms, right? It's going to depend on the symptoms and what's going on with the patient. It's standard precautions, but obviously standard precautions encompasses lots of different things depending on the activity that you're going to be doing, okay? So aerosolizing by the use of respiratory tract devices, humidifiers, nebulizers, steam rooms, all of basically just think of anything that could aerosolize water, and there you have it. And there's been so many outbreaks related to Legionella. I remember I was at a local conference in Florida where they were talking about a water fountain that was linked to a Legionella outbreak in a long-term care facility. And that was also very interesting. But Legionella infections can be traced to multi-species biofilms. So biofilms, you guys know how I feel about biofilms. Biofilms are just like the coolest thing ever, all right? It's exciting. The papers are always just bumping with science and knowledge, and I said what I said, I feel how I feel. So Legionella, along with various protozoa species and different bacterial species, will enter our drinking water systems, and then they'll be absorbed into the biofilms. You've always got your colonizing bacteria, so that little first colonizing bacteria that starts to make it all happen. And then little bits and chunks will break off over time. So you've got pictures here of what this looks like, of what that biofilm looks like inside of the piping. And those are like pretty mild. It's not too bad. There's some really intense pictures of biofilm. So diagnosis, how do we diagnose this? There's got to be a clinical awareness. You've got to know to look for it in order to find it. Definitive tests, so isolation of organism by culture. like sputum, lung tissue, pleural fluid, tracheal aspirate, bronchial washings, PFGE testing for subtyping, and again, urinary antigen tests, which is going to be the most common. Limitation with that is that it's only able to detect Legionella pneumophilus or group 1. What are some of our treatment options? Are quinolones, levofloxacin, ciprofloxacin, and macrolides such as zithromycin and clarithromycin. And our therapy of duration is usually going to last from 10 to 14 days. Prevention. We have to have water safety plans in place, and we need to know about our disinfection systems. So there's an entire different lecture that will focus on our WICRAs, so focusing on our water management programs, talking about the different types of disinfection systems that you should have. Yeah, very important, but some of the things that you need to know about is superheating and flushing, hyperchlorination, copper silver ionization systems, chlorine dioxide, monochloramines, and point of use water filters. And that's a hot topic, that very last one. So let's go through some questions quickly. So pneumonia that develops 40 hours after hospitalization in a patient without previous healthcare contact for 6 months, but with current oxygen therapy would be classified as A, healthcare-associated pneumonia, B, hospital-acquired pneumonia, C, community-acquired pneumonia, or D, ventilator-associated pneumonia. Okay, I have B, D, lots of C's. Okay, so C is the winner, which is correct, community-acquired pneumonia. Pneumonia that develops 40 hours after hospitalization in a patient with previous healthcare contact for 6 months, but with current oxygen therapy would be classified as community-acquired because the patient was admitted from the community and pneumonia occurred less than 48 hours after admission. Now, it's important to know that for our NHSN definitions, we work with calendar days, but you can't get to past calendar day 2 with the hours that they provided. So the most common cause of community-acquired pneumonia in adults is A, methicillin-resistant Staph aureus, B, Haemophilus influenzae, C, Mycoplasma pneumoniae, D, Streptococcus pneumoniae. The most common cause of community-acquired pneumonia in adults. Okay. Okay, so I've got some A's and not a lot of answers. Not a lot of people are posting answers. I've got a B now and 2 D's and then a C. Okay, we chose every answer choice possible. The correct answer is Streptococcus pneumoniae. So Streptococcus pneumoniae is going to cause about 20 to 50% of our cases. Mycoplasma pneumoniae is about 20 to 30%. Haemophilus influenzae is at increased risk in children and older adults, but it's not very common. And then community-acquired methicillin-resistant Staph aureus is relatively rare. So we see it, but not as much as we would see Streptococcus pneumoniae. All right, so the current community-acquired pneumonia national quality measures used in the United States include all of the following except A is antibiotic timing within 6 hours of arrival. B is antibiotic selection. C is blood cultures performed in the emergency department before antibiotics were administered. And D, ensure that all patients are screened for pneumococcal vaccine. Okay, very good. Very good. The majority of you are putting D, yes. Yeah, and so you have to be very careful with statements like all, none. You have to pay attention to that when you're taking the test. Yes, there's going to be times when those are going to be the correct answers, but you need to pay attention because whenever you're seeing like ensure that all, none, those really statements that are phrased in that way, you have to make sure that you really analyze what it's trying to say. So here are the core quality measures, set of standards defined by the Joint Commission, CMS, for community-acquired pneumonia, which includes an oxygen assessment within 24 hours before or after arrival at the hospital, Patients over the age of 65 screened for pneumococcal vaccination and administration before discharge if necessary. So it's not going to be all of our patients, just those over the age of 65. Blood cultures performed in the ED before antibiotics were administered. Obviously, we don't want to delay treatment, so keep that in mind. But yes, we want to try to get them before we give the antibiotics. Antibiotic timing, so within 6 hours of arrival, antibiotic selection, adult smoking cessation advice and counseling provided, and then obviously our influenza vaccination. Question 4. There's an outbreak of waterborne pathogens in your healthcare facility, but the only information you have about this outbreak is that it is related to contaminated equipment. Based on what knowledge Based on that knowledge, which of the following organisms would be more likely to be the cause of the outbreak? A is Cryptosporidium parvum, B is Legionella pneumonia, C is Pseudomonas aeruginosa, and D is Mycobacterium tuberculosis. So the two pieces of knowledge that you have, it's that it's related to contaminated equipment and that it's a waterborne pathogen. So with that, which one do you think it is? Oh boy, we have A, B, C, and D. All of them were selected. Everyone said every answer choice was submitted. Okay, we've got more bees. It looks like the bees are winning. It looks like the bees are winning. I know, you would think. She just talked about Legionella. Of course it's going to be Legionella. No. Remember, aerosolization. Pseudomonas and non-tuberculosis mycobacteria are the waterborne pathogens that are most associated with outbreaks related to contaminated equipment. Tap water that is used to rinse instruments after disinfection and as a water source for medical instruments may be a source of those infections, which is Pseudomonas indeed is my favorite. Pseudomonas aeruginosa, she is indeed my favorite. She's dangerous. She's a threat to society, and I have nothing but respect for her. So, gotta love Pseudomonas aeruginosa. Okay, question 5. A patient has been diagnosed with Legionnaire's disease that was possibly acquired during his stay in the hospital. What is the recommended first response to this incident? A, and this is the last question, guys, because I do have to head to another meeting. A is all water sites in the healthcare facility to which the patient was exposed should be cultured for Legionella pneumonia. B, the patient should be placed on respiratory isolation until 24 hours after treatment has started. C, the water system should be superheated and flushed immediately. D, all patients should immediately be provided with bottled water for drinking. So we think somebody got Legionnaire's disease from a facility. So they've been there for many days, and all of a sudden they got Legionnaire's disease. What is the first thing that we're going to try to do? Oh, I think, okay, so based on the answer choices that I'm getting, I think we need to reread this chapter. I definitely think we need to reread this chapter because I'm getting lots of D's. I understand the C's. But the D's, I don't understand the D's. So this is a question that actually caused some discussion because essentially, yes, we want to try to make sure that we get our cultures from the water sources. Absolutely, 100%. What I can tell you is that there are times when these investigations take time. So if you really truly suspect that you have a Legionnaire's case or Legionnaire's disease associated with your facility, then you need to, one of the first things that I would be trying to figure out is obviously culturing, but the health department a lot of the times wants to be that party that does it, but they can take a while to respond. So I understand why the answer is A, but I also understand why many of you would move towards C, that the water system should be superheated and flushed immediately. So ideally what you would do is you would collect your cultures as soon as possible and then get to flushing the system, even before you have before you have the results back. Because if there's a suspicion that this has happened, you need to get in touch with your water management agencies, or your water management program, um, your facilities, all of your people, and figure out how are we going to do this, how can we superheat the system, what can we do to try to fix this if that's what the suspicion is. Okay, so we still had quite a bit of questions to go over when it came to viral hepatitis, but I do have to head out to a critical care meeting, so I have to go. um, I will be in Virginia next Friday. I am attending a meeting for APIC. So I will not be able to do the course next Friday. So I do apologize. I will do my best to send out an email this weekend, to notify you all that we won't be meeting next Friday because I will be out of state at a meeting. So for those of you who come every Friday, you guys know, no meeting next Friday. I haven't had the time to figure out how to do this invite thing, and I don't know if I'm ever going to have time to do this invite thing because there are so many projects and things that I'm currently working on that if it happens, it happens. If it doesn't, it doesn't. Those of you who come, I'm grateful for you, and I hope that you get lots of good information and that you learn. But I will see you guys after that. Okay, so have a good weekend. Make sure that you're studying, that you're reading all of your chapters. And for those of you who may be testing soon, good luck and goodbye. Sybil, I'm coming.